As Justin said, my name is Alison Dwyer. I'm a consultant nurse down at Salford Royal. And I'm going to talk to you about this quality improvement project that we did over last year. We are now Salford Royal, which was the old Hope Hospital, and that's our new Hope building up there. And this is our pain nursing team. You'll probably see some other photos of our bigger team members as we go along, but that's our nursing team. We cover the acute pain service and inpatient service 8 till 8 Monday to Friday, and also Saturday and Sunday mornings, and a variety of outpatient clinics as well. So there looks like there's a lot of us, but we have to work extremely hard to cover all our responsibilities. So in terms of managing pain in hip fracture, I think this was one of the places that it started for us, the NC-POD report, which was looking at a review of care received by elderly patients undergoing surgery. And we were looking at around the same time as well about how we manage pain in older people anyway, in terms of our assessment and management of them. So the two sort of fitted quite nicely together in terms of putting together a quality improvement project. But NC-POD actually identified some interesting facts, I suppose, for us really, is that falls represent half of unplanned admissions to the accident and emergency department. These are mostly older people over the age of 65. And the most common injury, so half of them again, is a hip fracture, a fractured femur. And from the National Hip Fracture Database, on a national level, we could see this is a huge problem. Over 70,000 hip fractures annually in the UK, predicted to rise by 2020 to 100,000, with an annual cost of 2.2 billion. So there's a huge cost associated with managing hip fractures. The average age in the UK is 80. Our local average age is 81, so slightly higher. And there's a mortality between 5 and 24% nationally. So a quarter of these patients may not survive their hip fracture. Length of stay, the median length of stay is around 20 days. So they're in hospital for a long time. And the reasons for that is that the patients come with complex issues. So they're older people. There may be many reasons that are surrounding the reason for their admission or their fall. So there could be multiple comorbidities, issues with polypharmacy, pre-existing cognitive and confusional issues, stroke, etc. So lots of reasons why they are presenting in a complicated fashion. A big issue, and again this was around how we're assessing and managing pain in older people, is around the issues of confusion. And in our older population, the older you get, the more likely it is that you're going to get dementia, and I think that goes without saying. If you're in your 80s, then there's a 20% chance that you're going to have dementia. And this is our patient population with the hip fracture. And also patients are at a high risk of acute confusional state as well, so an acute delirium following admission to hospital. And it is, again, a common presentation for older people. Around 45% of older patients admitted to hospital, unplanned surgery, will have an episode of confusion. So that is a big issue for us. It's associated with adverse outcomes. But we know if we assess patients and identify it, then or identify patients at risk, then that is preventable. And these are two key issues in terms of pain management, because what we're doing with our elderly patients, we don't want to add to issues of increased confusion. And some common things that we know, so dehydration, constipation, infection, changing locations constantly, can all add to this particular problem. So back to NC-POD. NC-POD said that pain is poorly assessed, that we manage pain preoperatively poorly, that in fact some patients don't get any analgesia preoperatively, that we're not assessing patients routinely, and that there are some particular skills that are required in the assessment and management of pain in older people. It's particular to older people as well. So why is that important to us? Well, the consequences of poor analgesia are well documented. If we don't manage pain well, patients will be less well. So they will have more complications in hospital, increased risk of chest infections, of DVT, of reducing longer-term rehabilitation and mobility. We will also have an impact on their cognitive and emotional function. Their length of stay will be protracted, and the overall patient experience, which is something that we're really keen on, will be poor. So we need to do this well. So in looking at moving our project forward, we looked at what standards were already out there. So in terms of guidance on what should we be doing to manage hip fractures, there's tons of stuff out there, from NICE guidance through to best practice tariffs, the National Hip Fracture Database, suggestions, guidance from NCPOD, etc. So there's tons of stuff there that's suggesting what would be best practice in terms of managing hip fractures. But one of the things that we wanted to overlay on that were the principles of enhanced recovery. And you're going to hear some more of that, about that, from Rachel this afternoon on a different group of patients. But this was really around having a standard of care for this group of patients that we deliver to everybody unless there's a reason that we cannot do that. And we know that that's associated with improved outcomes, so reduced complications, and again impacting on our length of stay. But this is about a quality of patient care rather than just getting bed days down. We also looked into the literature as well in terms of what guidance was around there, or what the reality of things was. And you know, no surprises, age is the highest risk factor for both pain and dementia. So you know, cognitive state is a key issue for us. We know that if you've got dementia, then you're going to have poorer outcomes following your hip fracture. And that we know that dementia and delirium are barriers to effective pain management, so effective assessment and administration of analgesia. The literature showed us that under-treatment of pain is common following a hip fracture and therefore associated with poorer outcome. And also, following hip fracture, patients with cognitive impairment have been reported to receive between 30 and 50% less analgesia than those the patients that are cognitively intact. So this was quite shocking. I felt that if you've got dementia, you're probably going to get half the analgesia that somebody that's cognitively intact will get. And if you then have acute delirium, then that will drop to around 30%. And that was quite striking, really, in terms of how we're trying to manage our patient group. As I've already said, standardising what we're doing, we know will lead to better outcomes. So that was really what this was all about. So our QI methodology, not the same QI as the Stephen Fry show, but certainly I hope it is quite interesting to you. But this is about quality improvement. So I don't know if people have been involved in quality improvement work before and the methodology around it, but I'll show you a little bit about it and also discuss some of our findings. So we wanted to improve the reliability of pain management in older people. So we wanted to make sure they were getting what we wanted them to get. And we actually set the standard, so the standard of analgesia prescribing. We wanted every patient to be prescribed regular paracetamol. And again, we know that that is a good analgesic, but also we know that where pre-existing agitation is present with patients with dementia, then that can also reduce agitation as well. Now, whether that's through pain relief or for other reasons, we don't know, but there's really good evidence that regular paracetamol is a key for managing pain in patients with cognitive impairment. So regular paracetamol. We also wanted them to have Oxycodone as our opioid of choice. Now, we already had that as a standard in the trust. So in Salford, if you are 70 or older, or if you have any renal impairment, Oxycodone is our first opioid of choice. That's the opioid you will be prescribed. So we wanted that to be our opioid of choice. The reason for that, clearly because of the reduced risk of confusion in association with morphine. We wanted to also look at opioid sparing techniques, and again that's something common with our enhanced recovery. So we wanted all our patients to have a fascia iliaca block. We wanted that to happen when they came to A&E, and we wanted that to happen when they went to theatre, so they would get two through their journey. And we wanted those areas to own that. So I know I've seen presentations previously around fascia iliaca blocks where you've got either pain nurses or some nurses from the recovery room that go off and do these blocks, either in A&E or do them in theatre. And we really wanted something. We wanted a process that was going to be sustainable. So we wanted our A&E staff to be competent to do this, to train their own staff to do this, and to be able to provide a round-the-clock service there. And then clearly our anaesthetists, I would hope, are competent and reliable in being able to do the technique as well. If that works well, then that effectively allows us to avoid any strong opiates. One of the other issues, which I've not really talked about in here, is about time to theatre, because actual surgery is the best analgesia for a fractured hip, and we've got quite long times to surgery, but that wasn't something that we could impact in our project, but that was a key issue as well. And then the other thing that was really important to me was to introduce an assessment tool for patients that were unable to reliably self-report their pain, because we didn't have that. And I think when we looked at the NC-POD audit, are we assessing pain regularly? Yes, we are. But are we using a tool that's fit for practice? We weren't doing that. We weren't using something that, you know, for patients that were not able to self-report. We didn't have a standard for that. So that was a key outcome again here. So 95% of patients are going to get our bundle of care. I think we were being a little bit optimistic there, and we certainly learned a lot on our journey. This is our driver diagram. It's quite a busy slide, and I don't know if you've seen these sorts of things before, but we've got the aim over here on the left, which I've just shown you, and then the things over on the right are the things that we needed to do to make this work. And one of the challenges was that these patients go through the hospital. So they come into A&E, they go to the orthopaedic ward, they go to theatre, back to the orthopaedic ward, and then they get discharged. And as a pain service, and I don't know about your acute pain services, but we've never had a lot of input into A&E. Very rarely have we been called to A&E to help with a pain issue. We do spend increasing amount of times on our ambulatory ward and emergency admissions ward now. But A&E's not been somewhere that we've been to before, so it's really a big issue about building relations there, getting to know people, and raising awareness of what we wanted to do. Had a fantastic consultant down there that was really keen in terms of blocks. They all have to be done with ultrasound guidance, and they've got a training programme in place to train their staff to do that down there. We have electronic prescribing across the trust everywhere apart from in A&E, so that was another challenge for us. And quite interestingly, they didn't even stock Oxycodone in our A&E department, so they just had morphine. So again, that was another challenge for us. They didn't have the things that we wanted them to have, so that was going to be an issue for us. In terms of the ward, the paracetamol and oxycodone was already part of our trust standard, so we didn't expect that would be a challenge. So what we wanted the ward to do was to pilot our pain assessment tool, and we used the Abbey tool, and I'll show you that in a little while, but I'm sure pain nurses in the room will be quite familiar with that anyway. And in theatres, we were again looking at were patients getting a block, were they getting their paracetamol, and were we doing pain scores in there. So those were the sort of key measures we looked at in those areas. All on the background of raising awareness of why this was important. So we produced some flow charts. I think you've got the presentation, so you'll be able to see some of this anyway. So we produced the flow charts for A&E, and that was step 1, prescribe regular paracetamol. Step 2, if they can have one, put a fascia iliaca block in. And if that's not working, then we're going to use some oxycodone. We do reduce the dose of paracetamol dependent upon weight as well. Okay, and then on the ward, the flow diagram for them was assess the pain using the Abbey pain scale, regular paracetamol, regular oxycodone as the opioid of choice if they were having that. And then again, a repeat of the fascia iliaca block in theatres. I'm not sure how well this comes up. This is a screenshot. We just changed to a new electronic system, so that's gone really smoothly and it's really easy to use, I'm sure you can imagine. But we've just swapped from one computer system to another. But this was a screenshot of our prescribing, our electronic prescribing, and in there we actually put in a prescription for patients that were admitted with a hip fracture, which included the analgesia that we wanted them to have. But it also included the other things that needed prescribing, so perioperatively the antibiotics and antithrombotics, etc. So everything was in there. So when the junior doctor came along to prescribe and he clicked on hip fractures, he could pick from that list the things to prescribe. So it's a bit of a reminder in there of what was needed. And that's great for patients once they're admitted, but again, that isn't something that was sort of viewable in A&E and still isn't at the moment. In terms of assessing pain, I've already mentioned what we actually chose to use, which is the Abbey pain scale. We looked at British Pain Society guidance, first of all, but we also looked at other dementia tools out there as well. We decided on the Abbey pain scale. It's a bit like, I suppose it's a little bit like the assessment tools that we used to using, so your categorical, mild, moderate, severe, or 0 to 10, whatever you're using. It's a very, it's a very broad tool. It's highly sensitive. So if your patient has got pain and they aren't able to verbally report, it will pick it up, but it isn't very specific. So these behaviours may actually be indicating other issues. So we accepted that, we took that on the chin. The reason we went with the Abbey pain tool is that it can be done in under a minute. So in an acute setting, it's a very usable and pliable tool for our different areas. We did look at the Distat and the PainAd, and I don't know again if those are tools that you're used to using, but they're quite lengthy tools and they're great tools for assessing pain. They're all dementia, pain in dementia assessment tools, and they're great for longer term care. But in the hospital, if you want it to be done reliably, it's got to be quick and easy, otherwise people won't do it. So that's why we went with this. We also, on the back of it, produced, we put a chart on the back to chart at least 5 times a day that you were doing a pain assessment, and for that to be done more frequently if it was required. But it was just so that patients were getting a regular pain assessment there as well. And again, a lot of you will be familiar with the algorithm for assessing pain in older people, which basically says if they can tell you, then listen to them, and if they can't tell you, you need to pick up on these other things, these other, other behaviours that may be indicating why they've got pain. But we need to be looking at and treating pain. So that's what that's about. So I'm going to show you some charts. I know that some people like this sort of stuff, some people are not that keen, but I'm going to talk you through what we found. So these are sort of run charts. So these go the time that we were collecting data. This was a paper audit. We looked at the paper notes. It was so when you do that, and I'm sure that you've all been involved in it, you don't sometimes get the reasons why, or you don't get the reasons why things happen there. But I'll tell you a little bit about this. Each one of these dots is a patient that came into A&E, and one of the part of the standard was to have analgesia within 30 minutes of admission to A&E, which we didn't achieve, but we were doing better towards the end. So each one of these is a patient, and our average on there is about 90 minutes. One of the difficulties was in terms of some of the spikes there where patients didn't get analgesia for a long time, was whether that was because they'd maybe had something previously. So patients did get analgesia in the ambulance, and we were able to pick that up. But it is difficult from a paper chart to go back and say, well, why did that happen? We didn't include patients that were elsewhere in the hospital that had fallen and fractured the hip. Not that we get lots of them, but we did get some of those patients that came through as well. So towards the end, I don't know if we've got a pointer. No. Towards the end, I think I'm going to do it on here. Towards the end here, we can see actually we were starting to do a little bit better. But when we did look at some of these spikes, we actually did find, and just going back to what we saw in the literature, that if you were younger, and you were able to say, this hurts, you were getting your analgesia within that 30 minutes. Whereas if you were older, it may take quite a bit longer. So that we did see that within our own patient population. This was the patients getting the block. So this was the fascia iliaca block in the emergency department. Now, I've got to say, our data is a little bit skewed because in July and August, this is just one patient in July and one patient in August because everybody's on holiday, so no data got collected then, so I have to apologise for that. But this is quite interesting as well in talking through the data. So this is done in the months and how many patients got it. So we had a drive on information, and in March and April, can I get the thing? So in March and April up here, when we were raising awareness, everybody got a fascia iliaca block. Obviously the summer happened, And then after the summer, when we started to raise awareness again, they started to go up again. And we're probably running around 60% at the moment with patients admitted to A&E that get a fascia iliaca block. We can do better. So we're still working with A&E and we're still doing education and training sessions, and they've actually got their own programme around training their staff to be able to do the block as well. So that's improving. Did they get an appropriate opiate in A&E? And again, this is quite interesting because in March we didn't have oxycodone in A&E. So this is a simple yes or no question. Did they get oxycodone or did they get morphine? Excuse me. So I'm not sure what happened in March there because they didn't have oxycodone, but that's what's recorded as the patient having had it. They didn't get the oxycodone till around August time. So in August, that's our one patient that did get it. We had a little bit, I don't think that consultants in A&E were that convinced at first about oxycodone, but it has taken off, and again with our further input and awareness down there, then that is improving. It took us a while to get into A&E, and I don't know what other people's experiences are, because we went and we said we want to do this project, this is what we want to do, this is going to be great, and they went, yeah, that's fantastic, or we'll share it with the team. We said, well, should we come along to your meeting and tell you about it? It's all right, no, it's okay, that's fine, yeah, it's dead straightforward, no problem, we'll go and share it. And it took a while to get off the ground until actually we went down and we said, do you know about it? Do people know about it? And they were extremely welcoming and really interested, but it just took a little while to actually get in there, somewhere that we'd not been in before. So I think certainly if you're looking at these sorts of projects, you really need to get in there, and you probably need somebody in the area as your champion to make this work as well. Pain scores in theatres, perfect, 100% all the time. Everybody that went to theatre got an appropriate pain score, and they did do an Abbey pain score in theatre as well. So that was fantastic news. That was happening. That was brilliant. Did they get a nerve block in theatre? Again, probably around 60% of the time. And that's probably what we're running at again at the moment there. Skewed our data by this one patient in August that didn't get one. It makes it look probably worse than it is. And did they get an appropriate pain score post-operatively? And this is this one. I think it's important to say that when we started in February, we went to our trauma ward and we gave them the chart and we went through it with everybody. We did lots of awareness, and that was brilliant. So around 80% of patients were actually getting the Abbey pain chart appropriately. The ward then moved so that they could have work done on it, and nobody got the Abbey pain because they all forgot about it. They'd moved on to a different ward while their ward was done up. So then when we went back to the ward and we did the awareness drive and we were running at 100%, brilliant again, and then they moved back and forgot about it again. So I think there is an issue about how you maintain a change here, because clearly that was the last thing on their mind once they moved between departments. But we're probably around 95% reliability with it now. One of the things that really surprised me as well is that it's not a lot of patients that actually you need to use a different tool on, because even patients with mild to moderate dementia can actually reliably self-report a lot of the time. So it's only a small proportion of patients that we're needing to use a different assessment tool on. Paracetamol post-op, 95% reliance on that, and that's continued, so that's brilliant. An appropriate opioid use post-operatively, and we probably run around 95% on that as well, again skewed by a patient in July that didn't get oxycodone. And that may well have just been one dose of morphine that they received. It's a simple yes or no audit. So we were nowhere near what we set out to achieve in terms of 95% reliance with this. However, we do feel we've made some significant changes, and we are still working towards achieving that goal. We have got an increased use of the fascia iliaca block, and people are very responsive to that. The nurses on the ward really like it when a patient gets a block, because they can actually care for the patient better. They can roll them, they can move them without patients being in severe pain. So it's less distressing for the patients, and it's less distressing for the nurses that are trying to deliver that care. So that's great. We've established oxycodone in A&E, and the reliability of its use has increased, as I was saying before. So that's really good news as well. We've increased awareness of regular paracetamol. We've got a lot of PRM prescribing for paracetamol, and that's really raised awareness there. And we've got the Abbey pain assessment tool established on our trauma ward. The palliative care team are really keen to use the Abbey pain tool, as are our dementia team as well. So we're now looking at using that trust-wide with some of our local adaptations that we think are going to be helpful in terms of its usability. And we've also got the post-operative prescribing bundles as well to try and improve reliability. Having the Abbey pain tool was a key part of the project for me, that we've got something in practice that is fit for its purpose, that we're using an assessment tool that's making our assessment of this patient group reliable, and that they're getting the analgesia that they should be getting. And that by standardising what we want for these patients from an analgesia perspective, that's actually improved staff's knowledge and confidence in actually getting on with the job as well. And I think that's something that we've seen. We protocolise a lot of our care in terms of what we want patients to have post-operatively, and that works really well in empowering nurses to be able to deliver what's required, but also then to challenge if something isn't prescribed in the way we want it prescribing as well. So they all add to this issue of reliability, and that's really what quality improvement is about. This isn't research. The audit data that I've shared with you isn't fantastic, but it's reality, and that's what we've seen on our wards, etc. So for us, it's now about embedding this in practice. We want an excellent standard of care that is compassionate for all older people that are admitted to Salford Royal. So that's our overall goal, and what we want to continue to work towards. So thank you. It's about the patient experience at the end of the day, and that's really what we're trying to improve. So thank you. I don't know if you've got any questions.
So we've got 10 minutes for questions now, if anyone has got questions. This is the moment.
If the patient, elderly patient, is also having a chronic pain medicines, we have to continue, what is your experience to continue, otherwise, the pain control.
Did everyone get that question? So the question was, if you've got a patient who's got chronic pain that is ongoing, do you continue with their normal medicines, or do you stop it?
And the answer is yes, we continue with the normal medicines, and depending on what that is. So if patients are coming with fentanyl and buprenorphine patches, we carry on with those. If patients come in on morphine, so again, we still get quite a lot of our old population coming on Zomorph. If they've come in as an emergency or a trauma patient, we would often swap that to Oxycodone. Again, that's just because of the issues with acute confusion. For regular patients, if somebody's come in for a routine hip replacement, then we wouldn't necessarily automatically swap them to Oxycodone. If they've been on morphine in the community and managed well on that, we may well leave them on that. But in a trauma setting, we would tend to go for something that's going to have less impact on causing more problems and complications. It might, yeah.
I think it's okay. I can. Have you found any trouble with your consultant anaesthetists accepting the guidelines that you're sort of putting in? Have they all said, "Oh well, it's my practice. I'll do what I will," or like I always have done, or have they been quite good about it?
I think historically we've shared a good relationship with our anaesthetists, and I think, again, as I said before, as a pain service, we do use a lot of protocols, and therefore, if the anaesthetists stick with the protocols that we're using, then as a pain team, we can then manage patients well. The nursing staff on the ward who do most of the work, they can manage pain well. If they want to do something different, then that often makes things quite difficult and ups the ante for the anaesthetist, that they're probably going to have more input. So I think historically we've worked really well as a team, and a big issue here is about sharing the information. So it's about getting those people on board, talking to. We've now got a team of trauma anaesthetists which we've been coming together while this project was on. So that gives us a specific group of people to say, this is what we're looking at. But they're all interested in that anyway. They're keen to put blocks in patients if they can do. So ideally a spinal and a fascia iliaca block is the combination. And they're dead keen to do that. And the A&E consultants were dead keen as well in terms of what we were trying to achieve. So I just think that, it was good. there weren't the barriers there that we expected to be there, I suppose. Because we did anticipate barriers, but I don't know, an anaesthetist may have a different opinion.
What I would say from my point of view is that in terms of the blocks, you can't necessarily influence that, but if you get enough ultrasound machines, people like to use the ultrasound machines, and that will sort of, and A&E have their own ultrasound machines, so they like to use that. So that interests people and makes them perhaps want to do the fascia iliaca block. What I would say is if anyone gets the opportunity to have electronic prescribing, or if you have it, the fact that you can make prescribing sets is the best piece of use, from my point of view, of electronic prescribing, because you can't force people's behaviour, that would be completely wrong, but you can guide them in a direction that they didn't know they were going. And so if we have a prescribing package for the over 70s and we have a prescribing package for the under 70s, and then we also have all these different little packages that people can type on for their different areas. So they have to be aware that those exist, but for anaesthetists, if they just write post-op in our prescribing, they get a choice of packages that they can then use, and that sort of drives behaviour. So we know that they're going to prescribe oxycodone because there isn't going to be morphine available to prescribe.
Hi. Do you ever find any use for using the lower dose sort of buprenorphine patches for patients who are perhaps got far down the line of dementia and they're struggling to take regular analgesia?
I mean, again, in the literature, it is one of the choices, and in terms of ensuring that patients with dementia, where we think they've got pain, where again they may be difficult with assessment, then buprenorphine patches have been used a lot in those patient groups. Again, as an acute admission, it isn't probably something that we would use over the acute episode, but it may be something longer term if we're looking at a longer term pain issue. But yeah, there is really good evidence for the use of sort of low dose opiates such as buprenorphine patches.
In inpatient situation?
Yeah.
Hi, two questions regarding oxycodone. One, how long do they need, in your experience, post-operatively? How many days do they need? And when they get discharged, do they get any pain relief in terms of analgesics? And compared to Oromorph, have you found, apart from less confusion, any other advantages compared to Oromorph?
I think the main advantage for us is around the cognitive issues, and that is the sole reason why we choose to use oxycodone in that patient group. Post-operatively, patients quite quickly reduce the amount of opiate that they're requiring. So they would step down, and we would step them down onto some codeine and paracetamol, but they would step down very quickly and not require a lot of analgesia. And again, we looked very carefully, and that's not in the data here because we really looked just over the post-op period. But we did look and compare where patients that were not self-reporting getting equal amounts of analgesia, and there was parity there for sure. But we did find very quickly that the amount of analgesia required drops off post-operatively.
There is another reason we use oxycodone actually, which it's because morphine is metabolised to morphine 6-glucuronide, and that has a variable excretion rate, and in the elderly it has an even more variable excretion rate. The other problem that we have with patients who are elderly is because we don't know how good their renal function is, that they will accumulate the morphine 6, and we have an increased risk of respiratory depression and needing to use naloxone. When we stopped using oxycodone in the elderly group, we found that we didn't have any episodes in the elderly of respiratory depression that required naloxone. So that's its other big advantage as well as its cognitive function.
My question is more organizational. How did you get around, or what problems did you face when you started the fascia iliacal block in A&E, about training issues, who could do it? Because we tried doing that in A&E, but we had a lot of people coming up saying we're not trained, we're not allowed to. So what are those organizational issues or training issues, I would rather say?
Well, we might share that answer, but I think one of the key things that for us was that there was somebody that was passionate about it in A&E. So one of she was a registrar, soon to become a consultant, was very passionate about it in A&E. We also have pain trainees, so I'm not sure what the programme's called, where they they train in the block.
We have a regional fellow in blocks, in orthopaedics, trauma in blocks, so they were also involved.
So they were involved in setting up the training. So there's been some regional training that's been going on around using a variety of blocks perioperatively. So there's that training taking place. They already had the equipment, and they were happy to use it. So I think that we were already in a good position in terms of starting to move that forward.
But who actually gives the block while the patient is still in A&E?
Who gives the block?
Yeah.
Either the consultants or some of the senior registrars are trained to do it.
A&E.
A&E consultants and A&E registrars.
Thank you.
So the question is, can you get your A&E consultants to buy into it, and are they excited enough to do it? And if they're not excited enough to do it, then you are right, it will fail every time, and that is the great difficulty. And that's, I guess, change management in whatever you do.
Thank you.
Hi, you've produced loads of audit evidence to show that you're managing to change behaviour in various staff groups and locations around the hospital. Have you actually got any evidence to show that what you're doing is effective and that you're reducing pain scores and increasing patient satisfaction and decreasing length of stay?
Well, I suppose that was the next step of our project, really, because what we wanted to look at was whether that was impacting on health outcomes, so whether that has impacted. And we haven't done that piece of work yet, but it is about, has that impacted on length of stay? Has that reduced the complications that patients are experiencing following admission for hip fracture? So has it had any direct impact on that? The difficulty with that piece of work is that we're also doing lots of other work around fractured neck of femurs, because there's a huge initiative around this, particularly around best practice tariffs. So things like getting patients to theatre sooner, are they getting spinals, are they getting thromboembolic prophylaxis, are we assessing them for confusion, and are we acting upon that to prevent that? So there are lots of other factors that will affect that data, but that is our next step in terms of is that the plan was to do a mixed piece of work looking at patient experience, staff experience, and also clinical outcomes. So maybe if you come back next year, we might have some of that.
I think our length of stay is reducing, but I don't think there is a factor that we could say that this was the response. I suspect the biggest impact we've had so far is by forcing orthopaedic surgeons to do DHSs within 24 to 36 hours, which is that's a much more bigger challenge than persuading A&E to do fascial blocks, I can tell you.
And to be fair, this was all we didn't actually need the orthopaedic consultants to do this. They're quite happy in whatever we do, pain management wise. It was really A&E, it was the nursing staff and the anaesthetists that were involved in actually getting this package together.